Hi everyone, welcome to 10-Minute Medicine. Today we're going to be speaking about alcohol withdrawal, and my name is Dr. Alia Sahni and I'm a foundation year trainee in the West Midlands. So let's talk about some of the symptoms that these patients present with. So of course, this is not an exhaustive list, and also patients don't have to have every single symptom. However, these are some of the most common symptoms that patients present with. So you will have anxiety, agitation, nausea, and vomiting. And remember, if they are vomiting, to keep an eye out for if there's any blood in the vomit, because what you need to make sure is that they're not having, any hematemesis. Also sweating, tremor, and hallucinations. And with hallucinations, you do tend to see the very classic, spiders on the walls or on the ceilings. Some of the signs that you'll see in these patients: fever, hypertension, tachycardia, tachypnea. And then one of the other things that just to be mindful of is that some of these patients can be quite aggressive. So just make sure to be careful in these scenarios. Of course, every trust has their own guidelines for alcohol withdrawal. However, this will give you a general idea of what to do if you can't find those guidelines, because this does match the NICE guidelines. So how do we assess these patients? So to assess for withdrawal, you want to use the CIWA-AR score. And that includes most of the symptoms that we've already mentioned. However, it also includes headache, whether the patient is orientated to where they are, any tactile hallucinations, any auditory hallucinations, and any visual hallucinations. So it separates those hallucinations out that we would have asked the patient about previously. The thing about the CIWA score is you want to make sure that the score, if it's under 8, they're very unlikely to be actively withdrawing at the time. However, if it's over 8, then it's optional to give medication, and that score continues on up. The management. So this is trust dependent. However, most trusts follow the same guidelines. You want to start chlordiazepoxide as a PRN dose. If based on what the patient tells you of how much they've been drinking, I usually start with about a 25 milligram PRN dose every 2 to 4 hours. And you then swap that to regular and reducing after 24 hours. So what you want to do is when you prescribe it, you put it as a range. So let's say 10 to 25. Based on the patient's symptoms, the nurses will accordingly give him the chlordiazepoxide. At the end of 24 hours, if he used, let's say, for example, 45 milligrams, then you start with a 45 milligram reducing regular dose. So it starts, 45 the first day, 40 the next day, and we keep going down until we're at 0. Then vitamin supplementation is very key. When these patients first present, you want to prescribe 2 pairs of IV Papronex thrice a day for 3 to 5 days, based on how confused the patient is. After 5 days, you want to swap them to thiamine, 100 milligrams thrice a day, and that will be lifelong. With vitamin B co-strong, it is trust dependent. However, it is no longer a definitive NICE guideline to also include vitamin B co-strong when swapping from IV Papronex. However, some trusts still continue to give both together, and that's both thiamine and vitamin B co-strong. So make sure to check your trust guidelines. Finally, monitoring bloods and LFTs. What you want to do is when these patients come in is have a baseline liver function test, and then make sure to monitor that those are improving or at least not worsening. What you don't want is a patient to go, to have decompensated liver failure or acute liver failure and for it not to get picked up. With the bloods, you want to assess for all the normal bloods as well, full blood count USNEs. These patients who do drink more heavily are at risk of a variceal bleed, so it's always worth doing a group and save as well, just in case. Finally, some things to be aware of. Delirium tremens. So normally this occurs about 24 to 72 hours after alcohol withdrawal. Usually patients who do present with alcohol withdrawal symptoms on a ward that hasn't been picked up prior doesn't usually present within the first 24 hours. And it doesn't always present as usual withdrawal symptoms. So you'll tend to see the more severe symptoms in patients whose alcohol withdrawal doesn't get picked up early. That includes hallucinations, delirium. Of course, delirium tremens itself are the convulsions. They become severely agitated and ataxic. If a patient is in delirium tremens, you want to treat it as a seizure. You want to give lorazepam as per your trust guidelines, which is usually 4 milligrams, but you need to treat it as a seizure. Once the seizure is under control, you then need to put into place the alcohol withdrawal treatment, which is the chlordiazepoxide and the Papronex. So The very important thing to be aware of with all these patients, and the reason why starting Papronex immediately is so important, is Wernickesencephalopathy. Wernickesencephalopathy is reversible, and by starting that Papronex, you can prevent them potentially progressing into Korsakoff's. And that's very, very important because Korsakoff's is an irreversible condition. Now, if you do suspect someone has Wernickesencephalopathy, some of the symptoms they would present with are ataxia, confusion, hypothermia, hypotension, memory disturbances, and sixth cranial nerve ophthalmoplegia. The most important thing is, if you do suspect someone has Wernickesencephalopathy, is it's very important to flag it up to a senior. So start the Papronex, start their treatment plan, and then flag it up to a senior because it is something that needs to be very closely monitored. All right, everyone, that brings me to the end of this teaching session. If you have any questions or have anything you want to ask us, make sure to contact us either on the website, on our Facebook page, or on YouTube, or even on Instagram. And we'll see you all